Okay. Had a little bit of luck here. Is there anybody else here online?
Hey, Dr. Brooks.
Hey, guys.
Hey. So I can hear you, Dr. Brooks.
Okay, I'm trying to get this to work here. So this is first time out. I'm seeing a lot of people who are logged in where it says that they're using older versions of this software. So,
oh, okay.
Yeah, so I'm going through this.
Hey, I'm here. Can you hear me?
Yes, who is this?
This is Mark Ward.
Yep, Mark from Oklahoma.
Yep.
And Vicky's here. Can you hear me?
I can.
Hey, we got the Oklahoma.
Everyone
All
from
right.
Oklahoma. Everyone from Oklahoma except for Jeff and Melinda are here.
Yeah, Mark, can you hear me?
I can. Is this
It's
Roy,
Roy.
or is this
Yep.
Nathan?
That looks like Roy.
That,
Yep.
yep. Sounds like it. So looks like I've turned everybody on here in terms of being able to talk.
Can you hear me, Dr. Brooks?
Yes, I can. Is this Kajal?
Yes, Dr. Brooks.
Okay.
This guy's career right now, his most statistical similars are Willie Mays and Mickey Mantle. Man, what is your confidence level?
Okay, we got looks like we got the other Oklahoma guy here on his webcam.
Okay.
Here.
I made
There
it.
he is.
Oh my.
Nice.
Could have gone the rest of my life without seeing that face.
I cannot see anybody else except Demi.
Yeah. Well, actually, I am.
We can see you.
Yeah. I am Demi here. So, Asia, are you with us?
Hey, I'm here.
Okay, so you can unmute yourself. Looks like we got Kelly with us. Kelly, are you with us? Nathan, are you with us?
I'm here. But
Okay.
I'm driving.
Okay, cool.
Can you hear me?
I can. Who is this?
This is Josh Vance.
Hey, Josh. How you doing?
Good.
Fantastic. So, this is why this is going to be fun tonight, because I have never used this software, nor have I gotten a second of training on this. So this is going to be very, very interesting here. Who can, when you guys are viewing, what are you viewing when you look at the screen right now?
A picture of Demetrius.
A picture of Demetrius. So the question is, I'm going to try to hide that mug. Okay, so
How do I hide my mug?
let me see.
Turn your camera off.
Yeah, put a piece of tape over your camera. Let's see here. Let me see if I can hide your.
Hide your
Yes.
camera. Hide your camera, Jeff.
Let's see.
Okay, so
I know how to physically hide it, but I don't know beyond that.
let me see here. Let me see.
My screen shows anybody that's talking, their name comes up.
Okay.
Yeah, mine too.
So Jeff's picture only shows up when Jeff's talking.
Okay, cool. So now we have to figure out how you can see my screen here.
And Kelly has a comment that she's here, but she can't seem to chat.
Okay, let me see if I can unmute. Oh, who is that? That looks like, is that Roy Adams?
Yep, that was me and my daughter.
Oh, So this was
A while ago, actually. I'm
Yeah.
supposed to change my Facebook.
okay. So Kelly, I couldn't unmute you, so I just promoted you to a panelist, and now I can see you. There. Hello. Let me see if I can't get you to be able to talk here. Well, you are unmuted on my end, but can you hear me? Okay. Okay, so now the next thing here is we got to figure out how you guys can see my screen. So can anybody see my screen?
I can't.
No.
Okay. So anybody that uses uh-oh.
Something happened.
Something.
That was Jeff.
I bet it's Jeff. He's trying to block himself.
Yeah, Jeff was drinking and fell off his chair.
He's trying to hide his camera.
I just hope he doesn't go to the bathroom or anything.
Oh yeah.
I can now though. I blocked myself out.
Okay. Kelly says now she can't hear anything.
Now she can't hear anything. So
Lost her audio.
Even worse.
Yeah.
see what I can do to help Kelly.
Her
I can
name
hear you
comes up.
now. Can you hear me now?
Yes.
Yes.
Hey, okay,
Yes.
I'm here.
Amazing. Yes, yes, yes. Okay, so how do we show my screen?
I see something green.
Ooh, there
That
you
was
go.
Jeff. When you see the green, that's Jeff.
Oh, okay.
Well, we can see you.
We can see you now when you talk.
Hi. You can see me eating my burrito.
Might have to hide your camera.
I can do that. I know. I was thinking about that. See if I pick my nose or something.
I'm picking mine right now and no one can see.
You can see the green screen again now.
This isn't going to go well.
This is like a bad intro to the people or something, you know? With all of those squares.
Okay, so guys, I'm pushing buttons here, and when anybody can see my screen, let me know.
Okay.
Otherwise, I'm going to be talking, and this is going to get real boring real quick here. So, sounds like Jeff fell off his chair again.
Again.
Yeah.
Jeff needs a seatbelt.
Let's see here. You know, I think the problem is the password I was given to log in as the host is really not letting me share my screen.
Okay, now I have a double screen with Kelly and Jeff.
And Jeff's green screen.
Jeff's green screen.
Okay. So how do we...
Well, did you use that ID number?
Yes.
Was it a number?
Yes.
Okay.
Yes, that's what finally let me log in here.
Yeah, because I sent you an email saying maybe try the ID number.
Yeah,
So.
yep. That's what got me in. So we're gonna. Zoom is unable to detect a camera. That's because I don't have a camera. I refuse to show my mug on webinar because you never know what I might do facial expression wise, and I don't want you guys to see that.
Especially when we answer stupidly, right?
Okay,
Exactly.
hold it.
Right, exactly.
Hold it. Wait for it.
There it comes.
Oh, there we go.
There we go.
There you go.
There we go.
That's
Fantastic.
impressive.
Okay. See, this is what somebody who spent half his life in school and has done 25,000 EMGs can finally figure out here. So
That means there's hope for me.
Yeah.
okay, looks like we are rolling here now. So how many of you were with me here 4 weeks ago when we did the first part of this?
I was.
Yeah.
Probably about half the people. And if you remember, and I'm going to scroll back here real quick, we probably remember this case here. I mean, this guy here.
Yeah.
And again, the common thread among all these patients were that they had shoulder pain, shoulder dysfunction, weakness, atrophy, pretty much, every one. And the purpose of this series is to show the different conditions that can cause these very, very similar, clinical presentations and, symptom presentations. So who remembers what the diagnosis on this guy was?
Axillary nerve.
Yeah, looks like an axillary nerve.
Yeah, this guy here had an axillary neuropathy following a car wreck. Then the first patient we saw, she had basically the same symptoms: shoulder pain, atrophy, dysfunction, weakness, lack of range of motion, following a proximal humerus fracture that required an ORIF. And on this view, we can see her surgical incision. We can see what appears to be atrophy here. But do we remember what the results of this?
Hers was
It was normal.
This was normal.
No
Okay,
neurological findings.
Yeah, so this was a patient who had a little bit of carpal tunnel, and had a little bit of cubital tunnel. But in terms of proximal nerve pathology, plexus pathology, nerve root pathology, that would have been the most likely culprits in her presentation. It appears that what this lady had here is a combination of disuse atrophy, adhesive capsulitis, and nothing neurological. Okay, so even though our test did not show anything, it still gave us a lot of information based upon the fact that there was nothing neurological in this. Okay, so let's get to the third patient in our case series here.
So, hey, Dr. Brooks.
Yes.
Hey, so the lady, her tests were all normal. Her EMG was normal. So what was her? So it's just atrophy?
It is, yes. It is basically a musculoskeletal issue, disuse atrophy, and adhesive capsulitis, just due to the trauma, from her injury. There was not any type of proximal nerve issue like an axillary nerve or suprascapular nerve. There was no plexus issues, nor was there any nerve root issues. Okay, so her issues were mechanical and musculoskeletal, and not neurological.
Neurological. Okay.
Okay, so our third case here. This was a patient I saw a little bit over a year ago. And again, look at the symptoms. Left shoulder, arm, and hand pain, paresthesias, limited motion, weakness, and functional loss. Pretty much every patient we've talked about so far has that same presentation. But what's different here is he reports his symptom onset was following a C5-6 and 6-7 laminectomy infusion posterior approach with hardware placement. So he said all this happened after he had his neck surgery. At the time that I saw him, he had not had any physical therapy. The only imaging he had were some plain film x-rays, which basically just showed that the hardware was in a proper position and had not shifted. Again, past medical history, really nothing, significant here other than the fact that he did have that history of that, multi-level cervical laminectomy infusion. And so he was sent to me by his family practitioner to assess for causes of his atrophy and his functional decline. And on this patient, again, the big thing that I saw on clinical exam was the degree of loss of musculature and wasting in his shoulder, girdle area. So again, his issue is on the left. Not super impressive here, although he's got some great tats here, but this really shows it here. Okay, yeah. He's got anterior deltoid, maybe even some pec stuff going on here, posterior deltoid. When we look at him from behind, you can see where he had a surgery, but you can see wasting in that in that infraspinatus region here, along with some more great tats. So just a lot of stuff happening, with this shoulder. Okay, you can see some scapular winging here. Clinical exam, again, very, very similar to what we've seen with these other patients. Painful range of motion, passive range of motion of his shoulder was essentially normal. Of course, he had some limitations in cervical range of motion because of his multi-level fusion. Weakness throughout the shoulder girdle region, even showing some weakness down into his elbow flexion, full-on supination. And this finding here should raise a few red flags. Yes, it's possible that some of that weakness could be due to disuse, but normally, and I was pretty optimistic, when I gave him, 4- out of 5. It was probably, closer to 3+ out of 5. Neurological exam. He had an absent left biceps and brachioradialis reflex. What does that tell us, guys?
A C5, C6.
Yeah, something probably very proximal going on here. Could be nerve root, could be upper plexus. At this point, we just don't know yet. He had some, altered sensation in his left median distribution. So, digits 1 through 2. Had some, positive, Tenels and phalanx. So again, very possible that in addition to what could be happening proximally, he may also have some underlying carpal tunnel syndrome or something like that. But, we're going to find out here. Okay, so did some nerve conductions first, as I normally do. Take a look at these numbers, and again, guys, this is a different format than what your systems use because I use a different system. But take a look at these latencies. Take a look at these nerve conduction velocities, these sensories, and tell me what's going on here. Analyze this for me. Obviously, we have the findings right here. So if anybody's out there brave, you can go read this here.
Yeah.
If we look at our median sensory latency, D3 to wrist on a prolonged, and with a sensory nerve, if the latency is prolonged, what else is abnormal?
NCV.
Nerve conduction velocity has to be abnormal also.
Right.
Okay, so mildly prolonged latency, mildly slowed NCV over that long segment. That transcarpal segment, from palm to wrist, again, a prolonged latency and a slowed NCV.
Yeah.
Ulnar nerve, radial nerve,
Pretty good.
Okay.
all normal. Why did I check the lateral cutaneous nerve of the forearm. What was my reasoning for checking this nerve?
For
Trunk?
Supination.
For what?
Trunk? Upper trunk?
Yeah, for something happening with that upper plexus. Okay,
Yeah.
either upper trunk or lateral cord. Okay, because this nerve here is the terminal extension of what larger nerve?
Musculocutaneous.
Musculocutaneous nerve, yes.
Yeah.
Okay, so this finding could be abnormal if we have any type of injury or compromise of the musculocutaneous nerve, of the lateral cord, of the anterior divisions, or of the upper trunk. Why is this nerve not going to be abnormal if we have a C5 or C6 lesion?
Because in dorsal ganglion, post ganglion?
Yes. So be more specific. For this nerve response to be abnormal, would the lesion have to be postganglionic or preganglionic? Postganglionic. And essentially all cervical nerve root injuries are what?
Preganglionic.
So our sensory nerve tests are going to be normal, even though that patient may have profound sensory loss. Okay, take a look at these motors. Take a look at the median and the ulnar.
Median slowed again.
Yeah, median, that's upper limit of normal or, latency. So not really that big a deal. How about with this ulnar nerve?
Oh, I'm sorry. I was looking at motor or sensory again.
A little slowed across the elbow.
Yeah, we have some slowing across the elbow, and that sort of fit with those abnormal unprovocative tests. Okay, so he's got a little bit of some underlying carpal tunnel and a little bit of underlying cubital tunnel. Now here's your money makers here. Take a look at the amplitudes of these axillary C-maps compared side to side.
Yeah, the amplitude's huge difference.
Yeah. Probably between the both of them, probably averaging about 75% diminished on that affected side. 75%. So there's this pathology is affecting about 75% of these motor axons, innervating these muscles. Okay, so that being said, what would we expect to see when we do needle EMG on this patient?
Some axillary loss.
Okay, be more specific.
I mean axon loss.
Axon loss. So what do you see? What do you see with acute axon loss lesions?
You see fibrillations, the sharp waves.
Yes, you see evidence of muscle membrane instability. So you can see increased activity, fibrillation, positive sharp waves. What else might you think you could see with this much of an axon loss?
Decreased recruitment.
Yes, alterations of normal recruitment. You could see a reduction in the number of functioning motor units, or you can even see fast firing motor units here. So let's see what our EMG showed. Okay, so deltoid, increased insertional activity, some fibs positives, infraspinatus on a positive sharp waves, supraspinatus, increased insertional activity, fibs positive sharp waves. Oh. Now it gets interesting here. Why did I check the rhomboids?
Is it a C4 as well?
Come up a level.
C5, okay.
It's a C5. This guy had a fusion at both 5-6 and at 6-7 with stable hardware. Okay, so I'm thinking, probably not that level if his hardware and if that spacing looks good. But what can happen to adjacent levels when this hardware is tightened down a little bit too much?
Inflammation?
It can cause inflammation, can cause compression there. Yeah. So again, rhomboid being abnormal, serratus being, a bit abnormal in combination with these, suprascapular innervated nerves, and with this deltoid, it's sort of pointing us towards that, C5 level here. So did see some polyphasic motor units. What's the, what does polyphasic motor units, what is that telling us? And in this patient, what
the nerve's trying to regenerate or heal?
It's trying to heal, and since we're seeing them this quickly, can we maybe determine which method is causing us to see these polys? Do we think it's collateral axon sprouting?
Yes.
Or do we think it's more axon regeneration?
Collateral axon sprouting.
Yeah. This is probably primarily collateral axon sprouting. And as advertised, we saw abnormal findings in the ability of these muscles to recruit motor units. Okay. I did not check paraspinals. Why did I not check paraspinals?
Surgery.
Yeah. The guy had surgery like 3 or 4 months previous. And if I stick a needle in a muscle that's been surgically divided and pulled away from the bone, what am I most likely going to see? My
muscle membrane instability.
Yeah. My screen's going to be probably full of fibrillations, positive sharp waves. So that really doesn't tell us that much. So again, be careful when you stick paraspinals. Okay, there's sort of a general rule that somewhere around 2 to 3 years after surgery, it could be somewhat safer, to check those muscles. But, and this is a big but, if your only abnormal finding are in those paraspinals in that surgical region, are we going to call pathology ever based on that? No, we're not ever, because those fibrillations and positive sharp waves can persist for years and years and years. Okay.
Dr. Brooks, question on that: if they had an ACDF,
yes,
you would check them then, correct?
You certainly could check them then. Yes.
Okay.
Okay, so
what's ACDF?
Anterior cervical discectomy infusion. They go in through the front part of the neck, and they will remove the disc, and they will use some sort of bone graft and a plate to help stabilize that level. Much cleaner on a procedure than trying to to chop through lamina and things like that, and really you don't have to divide muscles, and those patients' ability to recover is much quicker. So that's almost the preferred technique now, unless they're having to do a lot of foraminotomy or other type of boning procedures. Okay, so what is our electrophysiologic impression on this patient? Based upon our EMG findings, how would you write this impression?
Axonal pathology affecting the L5 nerve root.
L5 or?
I'm sorry, C5.
C5. Yeah. Can we entirely rule out, C6 here? Probably not. And the way that I tend, to write this, when I see the rhomboids involved, I'll typically say C5 greater than C6. Because again, whoops, getting happy fingers here. We just cannot entirely rule out that there could be some 6 involvement. What muscle, and this is going to be me implicating myself, what muscle could I have stuck that would probably have tilted the table, if it was normal, almost totally to C5?
Is it FCR?
No, I checked FCR. FCR is primarily C7.
Okay.
What's that muscle underneath the FCR?
The supinator?
Pronator teres?
Pronator teres.
Mhm.
Pronator teres. I should have probably stuck the pronator teres on this patient, and if it would have been normal, because it's a primarily 6 muscle with a little bit of 7. If that muscle, would have been normal, then I feel very strongly that this was C5. What other muscle could I have stuck that, if abnormal, would have really tilted me towards C5?
Biceps.
I stuck
Or
the
you did
biceps.
bicep.
Yeah.
Brachialis.
Brachialis, absolutely.
Yeah, you know something.
Yeah, that's a very good muscle, a primarily C5 muscle. But again, this just shows that no EMG is perfect. And when you are working with these patients, it's a lot easier to, Monday morning quarterback this stuff than when you're doing this on the fly here.
Dr. Brooks, on the left bicep, would you have expected to see some abnormalities drilling based on
normally,
everything else?
Yeah. Normally I would, but in him we didn't.
Yeah.
So, what does that tell us, Mark?
Pretty weak too.
It was.
What does that tell us? Yeah, I don't know what it tells us.
It basically tells us that we're all not wired the same, and we're not all wired according to the textbook.
Okay.
And it's very possible that this patient's contribution to his biceps was probably more C6 than C5. Okay. And probably half the C6 radix that I see have normal biceps. Almost all of them have an abnormal deltoid.
Interesting.
Okay, but about half of them have normal biceps. So what muscle do I go to next, to show a C6?
So pronator, you said, huh?
I go to pronator. Absolutely. Okay. So yeah. So patients are not going to fall into the cubbyhole, like you want them to. This guy had weakness, in his elbow flexion. This guy had weakness of, supination, but EMG of his biceps was clean. And it's possible that my needle was not in the area where the abnormality was. Okay, but we can only report, what we find here. Okay. So again, his biceps were clean, but there were other muscles that were abnormal that, led us, to that correct area. Yeah. Okay. He also had some carpal tunnel. He also had some stuff happening with his, with his ulnar nerve at the elbow. Why am I fairly confident in saying that he probably did not have any type of plexus issue? What would I have seen abnormal if this was a plexus issue?
You would have more peripheral nerve or sensory loss.
Sensory NCS abnormalities.
Mm-hmm.
Okay, and in a plexus issue, what component of that sensory examination, is usually abnormal? Is it latency? Is it amplitude? Or is it nerve conduction velocities?
What are the options again?
Latency, amplitude, or nerve conduction. What component of that sensory test is normally abnormal in a plexus lesion?
Amplitude?
Amplitude, absolutely.
Yay.
Yeah. Why wouldn't latency or nerve conduction be abnormal?
Because we check the distal portion.
Yeah. We are doing our test distally. Okay.
So where there's no effect unless there's a local effect.
Exactly right. So those sensory amplitudes are critical in establishing that there's a plexus lesion. Okay.
Yes.
Okay, so after this test, this guy went and got a CT. Obviously he couldn't have an MRI because he's got hardware in his neck, and lo and behold, CT showed a large disc protrusion at the 4-5 level with calcification, central canal stenosis, high-grade severe left foraminal stenosis with severe compromise of his C5 nerve root, also including effacement of the dural sac and increased intensity of his spinal cord.
So they tightened him down so hard that they basically compressed his disc.
They basically extruded his disc for him. Okay, because this guy had MRIs prior to his surgery that did not show this. Okay, so whatever happened, this happened. And again, do I know if it happened during the surgery or after? I don't know. But these findings were not present prior to his surgery. I mean, he could have fallen down and landed on his head. I don't know. Okay. All we can deal with is what we have in front of us.
Yeah.
So this fits with what we saw with this patient. I mean, it's very rare, to see the combination of severe, neuroforaminal stenosis and central stenosis at that 4-5 level. I mean, that's actually a pretty rare bird. I see, I might see 5 or 6 C5 Redux a year, and I do over 1,000 studies a year, and I see maybe 5 or 6.
Mm-hmm.
Okay, so again, a very rare finding, but what's critical is you've got to stick those rhomboids. Okay, so we've got to be good at doing that, and then secondarily we got to be good at sticking that brachialis also. Okay, but what puts this over the edge from 6 more to 5 is that very abnormal rhomboid, because that rhomboid major is.
You mean 5 more than 6?
It is almost purely C5.
C5.
Yeah, 5 more than 6. Yeah.
Yes, 5 way more than 6, like 95% 5, maybe a little bit, bit of 6.
Right.
Yeah. Okay, so again, very interesting case who presented clinically just like all these other patients. Okay, the same presentation, pain, lack of range of motion, lack of function, paresthesias, muscle atrophy. Okay, and our diagnostic test was able to determine that this was a neurological compromise, and it helped us to determine the site of that compromise. Guys, I'm not going to go through this because those of you that have trained with me before, you all have this. Again, this is based on a study done by Tim Dillingham in the late 90s. 2% of the patients had a C5 Redic, the rarest of the rare. Okay, followed by C8 Redics. Okay, so very, very rare that you'll see this, but you got to be able to recognize it. Again, this is going to be for you guys to look at here. Just some things to help differentiate on clinical exam. The difference between 5 versus 6, versus 7. In a C5 radic, that dermatome is that lateral upper arm region. Okay, C5 radics do not get down into the fingers. Okay, this guy here had paresthesias in his fingers, and that's where the nerve test helped to confirm that he had some underlying carpal tunnel and some underlying cubital tunnel here also.
That they weren't related to the nerve root issue.
Is it possible,
Yeah.
Kelly, that he may have had a little C6 involvement getting down to digits 1 and 2? Is that possible? Yeah. There are very good limitations on our test. So we can't rule that out, and that's part of the reason, in my impression, that I said 5 greater than 6 here. So,
got it.
Okay, so prognosis. What's the prognosis for this guy's shoulder with that much axon loss?
Bad.
It's guarded. Okay. Obviously, he has severe axon loss, but guess what the good thing is? Those muscles are close to his neck. Those nerves,
right, they could grow back.
They don't have that far to grow back. Okay, if this was a C8T1 and his whole hand was atrophied, forget about it.
Right.
Okay? And he's right at the cusp. Okay, you've heard Dr. McKibben talk about trimming the canopy of a tree or, trimming the canopy of a bush. Somewhere around 75%, if you cut away between 75 to 80% of the branches in either a bush or a tree, the chances of that tree or bush surviving is poor. Okay, so he's right, he is right there.
Say that again.
Okay, so with axons, if we relate axons to the branches in a tree, okay, if we go out with a chainsaw and if we saw away 90% of the branches in that tree, is that tree going to survive?
It's going to have a harder time.
The tree is not going to survive. Okay, so in axon loss lesions, if we damage 90% of axons, the chances are of that muscle ever becoming anywhere near normal again is very, very poor. Okay, so the cutoff is somewhere around 75%. If there's about 25% of the axons still functioning, if there's about 25% of the branches left in that tree, then there's a fair to guarded chance that that tree will survive and that muscle will get some reinnervation.
And you're pulling that estimation off of the activity that you saw in the rhomboids?
We are pulling that. That's a great question. We're pulling that off of, go back to my nerve conduction. If we look at the side-to-side difference in our amplitudes, recording off the deltoid and off the infraspinatus, on the deltoid, it was 76% diminished on his affected side. That gives us a rough estimate of the percentage of axons that are compromised. Off of his infraspinatus, it was 74%. So you average that, that's right at 75%. So,
okay, so the motor testing.
Yes, this is the motor amplitudes reporting off the deltoid and off the infraspinatus. Okay, so he's right at that cusp of whether this can maybe turn out fairly good for him or it may not turn out. Needle EMG doesn't tell us anything about severity. It doesn't tell us what percentage of axons are involved. But motor CMAP amplitude is your best indicator of prognosis. Write that down if you don't already know this. Motor CMAP amplitude is your best indicator of prognosis.
Hey, Dr. Brooks.
Yes.
Where do you get how did you calculate the percentage?
You take 2.1 and divide by 8.6.
Oh, okay. I get you.
Yeah, being a very simple calculation.
Yeah, I get you. Okay.
Dr. Brooks?
Yes.
In EMG, the recruitment, inference pattern, can it give you the idea about how much axonal loss? Not exact percentages, but
yes. And since you've trained with me, you tell me, give me an example of what a poor outcome might be. You've got that needle in that guy's deltoid, and he's pushing as far, as hard as he can.
And if you can get only 1 or 2,
if you're only seeing 1 or 2 motor units firing, and they're firing super fast, 30, 40, or 50 hertz,
they can't get any more.
That means there's not enough axons out there to innervate those muscle fibers.
And Dr. Brooks, with that, can we differentiate? Then we can be sure that this injury is not conduction block or reduced amplitude, because
still don't know if there's not a conduction block component. We just don't know. And the reason we don't know is we cannot stimulate easily proximal to the side of the lesion.
Yeah.
Okay, so this guy's lesion is in his nerve root. How do we stimulate the nerve root proximal to where the compression is?
But from EMG, can we tell that it is axonal loss and not conduction?
In this case, you can, because you've got fibrillations and positive sharp waves. But what if the only abnormality was reduced recruitment? In that case, you probably couldn't, because a 90% conduction block may only show a few functioning motor units, but what it's not going to show is fibrillations and positive sharp waves.
Right. Well, what would be the causes of a conduction block at that level?
Compression, swelling.
Temporary.
Temporary, but after 3 months of symptoms, is it possible that it's beyond temporary? Is it possible that neuropraxic lesion, that compression that's been there for 3 or 4 months, is it possible now that it's, in addition to causing myelin changes, is it possible that it's now killing axons? Absolutely.
Right, if it's there long enough. So the more you have to get, because one of your red lines was, is this still going on? So did he end up having a revision in his fusion?
Well, tell me, is this ongoing?
Well, it looks like it to me.
Yeah.
Yeah, it is.
I mean, he still has muscle membrane instability. He still has those abnormalities on recruitment. Absolutely it is. Yeah. And what also makes me think that this is ongoing is we're seeing fibs and positives in the proximal muscle, like the deltoid, and we're also seeing it in a more distal muscle, like the rhomboid, and like the serratus. So one of the things that I utilize to decide if this is still an active, ongoing process, are we seeing these abnormalities both proximally and distally? And in this case, we are. I bet you if I'd have stuck his neck, and assuming that he didn't have posterior coach surgery, I bet you I would have seen fibs and positives in his neck also. Okay? So that tells me that this is still active and ongoing. What if we only saw it in a distal muscle? Say, for example, let's switch bases. Let's say, an S1 redict. Okay? So say we saw abnormalities in, say, the med gastroc and the tib posterior. But what if the short head of the biceps the glute max, and the paraspinals were all normal. At that point, could we say that this is still an active process? Are we sure that this is still an active, ongoing process?
No.
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 No. Yeah. Yeah. How long can fibs and positives persist in distal muscles after, after the injury? How long can you see fibs and positives in a medial gastroc after an S1 injury? Somebody say years and years.
Years and years.
Years and years. Yeah. But if you see the pattern of ongoing proximal involvement, i.e. paraspinals and glute max, along with distal involvement, medial gastroc, posterior tib, that tells you that the whole process is still going on, because it's going to get better proximally to distally, right? Normally, right?
Yes.
Yeah.
Yeah.
Yes.
Yeah. Good questions. Very good questions. I like this.
So is the patient going to have another fusion, another level?
This guy never showed up again.
Oh.
Most likely, and again, I'm from Kentucky. Okay. Guy probably got a lawyer, probably got a second opinion, and he never came back.
Yeah.
Okay, so I don't know.
Because you were performing that in the physician's office, correct?
I did this in the spine surgeon's clinic, correct? Yep. Okay, so holy cow, it's 8:30, but we're going to continue if that's okay with you guys.
Yeah.
Yeah. Good.
Yes.
Okay, so here's our next patient. Saw this guy July of 2017. Look at the symptoms. Shoulder pain, arm and hand pain, paresthesias, limited motion, weakness, functional loss. Here's what's interesting, though. Symptom onset 5 weeks earlier. And here's how his symptoms started. Very acute onset of severe shoulder and neck pain with no history of injury. And then after about a 2 to 3 week period, his pain was about 80% gone. But about 1 week after his onset of symptoms, he started to have shoulder and arm weakness, and he has noticed over the past 1 to 2 weeks, so about 3 to 4 weeks after the onset, significant atrophy in his shoulder.
Wow.
Are you still on?
I mean, he's not a particularly healthy looking guy to begin with here, but okay, again, look at his clarifying exam. Okay, atrophy, shoulder girdle, deltoid, venous spinatus, biceps, pectorals, even down into the forearm muscles here. Scapular winging. Again, same type of presentation. Severely restricted, painful shoulder, actively in terms of range of motion. Weakness, significant weakness. And again, I tend to be sort of optimistic when I assign, a strength, grading scale. Okay, I called it 4-. By God, it certainly could have been 3 or 3+ here. Okay, this guy had no imaging, nothing done at the point that I saw him, and that's what I sort of like about what I get to do is a lot of times I'm not getting these patients that have been through 9 to 12 months of treatment, and they're just now sending them to me to try to figure out why they're not better. Okay, so I get to see these guys, up on the front line here. Absent reflexes. on that left side, just like that previous patient. What was interesting, he said his light touch sensation was intact, and he really didn't have any positive provocative tests here. Okay, so let's go through this. If we look at his median, and this is over the long segment from wrist to D3. This is wrist to palm. Those are normal. Ulnars here, normal. Okay. I did his left radial. His amplitude was only 8.6. Normal is 10. So what do you always do if you have a low amplitude response on one side?
The other.
You check that nerve on the other side. I checked his other side. Look at that amplitude. 22 versus 8. Okay. I went and did his lateral cutaneous nerve of the forearm. And on his affected side, it was somewhere around 1. And I did it twice because I just wanted to make sure. Then I did the right side, and it's 7. Okay, so we've got a couple of sensory responses here that are telling us what, guys? What did we just talk about in terms of what sensory responses tell us about?
Plexus.
Plexus. Possible upper plexus. Something going on, in that upper plexus.
In the peripheral nerves, you have to say it's peripheral, not
it
root.
Is distal. It's distal to the dorsal root ganglion.
Yes.
Yeah. Okay.
In terms of exactly where, depends on where you're testing. Because if you're all the way, yeah.
Now, tell me, based upon that abnormal radial and that abnormal lateral cutaneous nerve of the forearm, is the lesion on the lateral cord or is it on the upper trunk? Both of them are abnormal, so where's our lesion?
I don't know, but for me, that brachial plexus is just like a big bundle of, I can't see clarity in it.
Yeah, so the radial nerve, this component comes off the upper trunk,
Okay.
traverses the posterior divisions, the posterior cord. Okay, whereas the lateral cutaneous nerve of the forearm,
hope you had a good time.
It's the terminal part of the musculocutaneous nerve. It's upper trunk, anterior divisions, lateral cord. So what's the commonality between these two nerves?
Upper trunk.
Upper trunk. This is something happening with that upper trunk, and this is something that you guys are going to learn as you do more and more of these exams. Okay.
In other words, it's going to start to pop off the page at us?
It'll pop off the page. You'll be laying in bed one night, and
I hope so.
and the plexus will be bouncing back, forth, in your head, and then you'll go, "I got this."
I look forward to that.
Yeah.
It took me about 2 or 3 years to really get comfortable with the plexus. And what'll be amazing is you'll be able to trace the innervation of these muscles, distal to proximal, proximal to distal. Okay, so the deltoid, okay, axillary nerve, posterior cord, posterior divisions, upper trunk, C5, C6. You'll be able to do that, back and forth here. Okay, so we've got a couple of abnormal sensory nerve conduction tests here. When we checked his median motor, it's normal. We checked his ulnar motor across the elbow, it's normal. Okay, so this guy does not have any abnormality, with either his median or ulnar nerves.
But those would be from the lower trunk, right? Middle and lower trunk?
Both of these are from the lower trunk, medial cord, correct. C8T1, okay? So he doesn't have any carpal tunnel. He doesn't have any cubital tunnel, nor does he probably have a lower trunk plexus issue. Okay. Now, I went to my same 2 go-to nerves. Look at the amplitude differences from side to side here.
Wow.
74% side-to-side difference of the axillary, and almost 60% side-to-side difference off of his infraspinatus.
Yep.
Okay, so what's our EMG going to show? I'm setting you up here, okay?
We're going to have lots of activity on those.
We're going to, okay, Vicki, stop right there. We're going to have lots of activity, okay?
Dips and sharp waves. Yeah.
Okay, deltoid, supraspinatus, infraspinatus, triceps, biceps, extensor indices, flexor pollicis longus, and middle cervical paraspinals were abnormal. What the heck?
Yeah.
Weren't we talking about this being an upper plexus lesion?
Yep.
Why are the paraspinals abnormal?
Don't know.
Okay. What is the nerve root level of the extensor indices?
Radio?
But what nerve root level?
Level.
Yeah.
C8.
C8T1, extensor indices, radial nerve, posterior cord, posterior divisions, lower trunk, C8T1. How about the flexor pollicis longus? What nerve root level is that muscle?
C5, 6, isn't it?
What innervates the flexor pollicis longus? What nerve?
Median.
More specific.
Anterior interosseous.
Anterior interosseous nerve.
Interosseous.
Yeah, anterior interosseous nerve. Median nerve. Medial cord. Anterior divisions. Lower trunk, C8T1. Why the heck are we getting C8T1 involved in a patient that we thought had an upper trunk?
Because he's got both.
Because they have carpal tunnel.
They don't have carpal tunnel. We just said that they don't have carpal tunnel.
No, we did.
Okay.
And what happened to this guy? What was the history?
And would the flexor pollicis longus be abnormal in a patient with carpal tunnel?
No.
No. Abductor pollicis brevis was normal.
Yeah.
What the hell?
Kelly, there was no injury. It
Oh,
was
okay.
Yes,
insidious onset.
acute onset of severe shoulder pain about 5 weeks previous. That got better after approximately 2 weeks, but at about week 3 to 4, he noticed significant weakness and atrophy of his shoulder girdle muscles. So no injury.
Mm.
Okay, reduced recruitment in those upper trunk muscles. Okay, so how do you write this crap up?
I'm calling you.
I mean, somebody tell me what the pattern is for deltoid, infraspinatus, supraspinatus, biceps, triceps, extensor indices, flexor pollicis longus, and middle cervical paraspinals. What pattern is that?
When you get back.
Well, I'm just thinking if you've got a neck thing that it goes down to the cervicothoracic junction, some kind of a mechanical injury that handles the upper trunk of the plexus, but then ends up with a disc issue at C8T1. Now you've got a combined kind of an injury.
That's a possibility, but how likely is that possibility, Kelly?
Unlikely.
Yeah. I mean, that certainly would explain what we're seeing.
Yeah.
Okay, but
I would naturally go there. Yeah, but what do you do next?
Yeah, so what do you do next? Okay, so
is there any sensory changes?
Sensory changes in terms of like like skin sensation changes?
Well, actually, I meant if the sensory study was normal or not.
In the sensory studies, there was a diminished left radial sensory and a diminished left lateral cutaneous nerve of the forearm, which all points to an upper trunk lesion.
Mm-hmm.
Okay.
Yeah. But what about thoracic outlet issue?
Oh, well, thoracic outlet is basically a lower plexus issue. Do we see anything here that is suggesting a lower plexus issue? If this was a lower plexus issue, we would expect to see those C8T1 sensory nerve snaps are diminished, and ulnar and median are normal here. So what caught my attention and what sort of told me what was going on with this patient before I ever did my first test on this guy, seeing that atrophy, seeing that there was no injury, he was telling me that he had a very acute onset of severe pain, followed by weakness and muscle atrophy. Does that compilation of findings suggest anything to you guys?
Get an MRI.
Very possibly. But
possible disease process?
Well, it certainly is a disease process. It certainly is a very acute inflammatory disease process. But that MRI is, that's to analyze those discs. Okay. How would disc issues cause those decreased sensory nerve findings? Those decreased amplitudes? It wouldn't, right? Because of the whole pre versus post ganglionic. Yeah. So what the hell is going on with this guy? And again, when you've got 23 or 25,000 of these things under your belt, you've hopefully seen about everything. Monday I had an ALS patient come into orthopedic clinic. Okay. He had been through the ringer with his family doctor, then to the orthopedist. His hand was atrophied, his forearm was atrophied, his muscles were freaking fasciculating like crazy, and none of those guys thought to think that this could be some sort of motor neuron disease. But that's for another webinar. Okay.
Right.
Yeah. So okay.
Well, it's a sudden onset that makes it interesting. And so you're looking at it. I mean, there was no other issues in his whole body?
Nope. Nada. Okay, so here's how I wrote this. And let's see if you guys agree. And those of you who would write it different, I would love to hear from you. Today's findings are complex. There is evidence of multiple nerve root involvement, preganglionic on the left, involving the C5 to C8 nerve root levels, including mid-cervical paraspinals. Additionally, there is evidence of plexus / more peripheral involvement, postganglionic, involving the left upper and middle trunks. When evaluated within the context of this patient's rapid onset of severe pain followed by muscle weakness and atrophy, these findings may be suggestive of an acute brachial neuritis with involvement of the nerve roots on the left. Suggest follow-up examination 4 to 6 months to evaluate neural reinnervation. Have any of you all ever heard of a condition called Parsonage-Turner syndrome?
Yeah.
Yes.
Ever heard the term brachial amyotrophy?
No.
Yes.
Yeah, this probably is what this guy has. Okay. Again, these are some of the terms, that you'll hear, brachial neuritis, brachial amyotrophy, neuralgic amyotrophy, cervical radiculoplexus neuropathy, diabetic amyotrophy, even though he was not diabetic, shoulder girdle syndrome, all of those, AKA Parsonage-Turner syndrome. Okay.
Is that kind of like a Bell's palsy kind of deal?
Very, very similar type of onset, more of like an acute inflammatory type thing happening there. Okay. Not very common. Okay. Generally it is idiopathic. There's no reason that it came on, but it's generally accepted that this is some sort of autoimmune, mediated process. There is a hereditary component to this. This process is seen within families and within, siblings. Precipitating factors, viral infections is the most common. In the military, the Army Marines have a higher rate of this condition.
With strenuous exercise, yeah.
Well, that and what happens on the first or second day when you're indoctrinated into the military.
You get immunized?
You get a crap load of inoculations, which sets off that autoimmune process there.
Right.
Then you add in the component of strenuous exercise. And so in the military, there's a 3 to 5 times higher incidence of this condition in new recruits because of these factors. Also seen after surgery. A patient who may have knee surgery may come down with a Parsonage-Turner syndrome because, again, probably because of the stress and, everything involved with this.
Okay.
In terms of a differential diagnosis, you got to be able to determine if it's a cervical radiculopathy, if it's a plexus issue, if it's some sort of other, mononeuritis versus something like a rotator cuff tear. They thought this guy had torn his rotator cuff. And again, with no history of injury, I'm not sure how that happens, but
they didn't know what else to do, right?
They didn't know what else to do.
The guessing world, right?
The call it the guessing world or call it the world of differential diagnosis.
Right.
Because that's basically what a differential diagnosis is an educated guess as to what you think is going on here. Again, I don't want to spend a ton of time on this. These are different studies that show the involvement of different nerves and different muscles. And look how these things, can be different. These first 2 studies, suggest, involvement of the suprascapular nerve. This last one, suggests a higher incidence within the posterior interosseous and the anterior interosseous nerves. Okay, so this thing is all, over the place. In terms of treatment, there are several good studies that show if this can be caught early, if you administer steroids and if you administer IVIG, that significantly improves these patients' outcome. Not only the speed by which they get better, but in terms of, limiting the amount of muscle atrophy.
Say that again.
Administration early on of steroids and IVIG, intravenous immunoglobulin G, significantly improves patient outcomes. They get better quicker and they have less, muscle atrophy and long-term deficit.
Do they do correlating for that kind of a thing? Is it enough with just the EMG?
There are 3 or 4 studies that show that this is very, very helpful and probably, the single best course of treatment. But the key is it has to be caught early.
Right.
It has to be caught early. A lot of times these patients, because they just think they'll get better or their insurance doesn't approve tests, a lot of times by the time we see these patients, it's months down the line, and by then, the damage is done on these patients. So Parsonage-Turner syndrome, brachial amyotrophy / unabrachial neuritis.
Hey, Dr. Brooks, is Guillain-Barré somewhat similar to that?
Guillain-Barré is another fairly acute autoimmune disorder, but Guillain-Barré affects all the nerves.
Yeah.
Okay, arms, legs, muscles of, respiration, facial muscles. This particular condition tends to affect the cervical / plexus region. Okay, again, 50 to 74% side-to-side deficit and amplitude. Again, he's right on that borderline.
Dr. Brooks,
Yes.
doesn't parsonage Turner also, isn't it selectively unilaterally? It's only one side.
Ah, let me go back because I didn't cover this. 30% of cases are bilateral and with subclinical involvement on that one side that maybe appears less involved than that other one. Of the 5 or 6 cases of these that I have seen, all of them have been unilateral. But I'll also be the first to admit there were a couple of them where I didn't check the other side because the patient had no complaints on that side. So certainly as a learning tool, as a take-home message, might be good to stick some of those muscles, on that uninvolved side, especially if your clinical exam suggests that there could be some weakness there. Okay.
So Mark, a case like that, how long did it take you to complete that test?
I did this test in about 40 minutes.
Okay.
Wow.
Yeah. Because I sort of had an idea, just from listening to them and looking at them, I had a pretty good idea of what was going on before I even stuck his first muscle there. Yep. So to do that one side and to do it thorough took me about 40 minutes.
Yeah.
Then it took me about an hour to figure out how I was going to word this report because of both the cervical nerve root involvement and the upper, middle, and lower plexus, involvement, here also.
Well, it's nice to see that the case actually even challenges you on the impression.
Again, that case I saw Monday, that 32-year-old guy with, which I think he has ALS.
Yeah.
He comes in, his, orthopedist, just saw the atrophy in his FDI and his APB and said, let's get an EMG. And, which is, to me, that's the right decision. Let's get an EMG. Let's see if he has carpal tunnel and cubital tunnel.
Mm-hmm.
So the guy's sitting there and his hand is fasciculating. His fingers are moving. I had him pull off his shirt. And this was before I did anything.
Mm-hmm.
And his deltoid and his pec is fasciculating. And then, he was scheduled in a 30-minute slot to do one extremity. And all of a sudden, oh shit, okay, I'm going to be with this guy at least an hour here now.
Yeah.
Okay, so after I did my nerve tests, which were all normal, other than the low amplitude CMAPs on his median and his ulnar nerve, what do you think the first muscle that I stuck was?
Deltoid?
Exactly right. I stuck his deltoid. Mm-hmm. And his deltoid had 2+ fibs and 3+ positive sharp waves. Okay. Then I went to his biceps, same thing. Went to his triceps, went to his, same thing. Stuck his extensor digitorum, same thing. Stuck his FCU, same thing. And then I stuck his, his FDI and his APB, same thing. Okay. Stuck his quad, 1+. Stuck his medial gastroc, 1+. Turned him on his side, stuck his thoracic paraspinals, 1+, 2+. Okay. Again, being able to recognize this stuff is super important here. Okay, guys, last case. This is a case that sort of rocked me from a personal level here. Saw this patient in clinic back in January of this year, and again, I'm not going to go through this whole history and stuff, but same type of presentation, okay? Atrophy everywhere. His history, go back here, onset of symptoms October of last year after a fall. Had some x-rays done in October that was read as glenohumeral joint degeneration and AC joint, arthritis. To me, I would have MRI'd his shoulder also, but they didn't do it. Okay. Referred to me by the PA to assess causes of the atrophy, including rotator cuff injury versus plexopathy versus axillary nerve injury. So I saw him in January, 3 months after after onset of symptoms. Okay. And again, I mean, this is really, I mean, look at that, guys. Okay. What's interesting, his biceps really are not atrophied, nor are his triceps. It's everything in the shoulder girdle region here. His main complaint, he wasn't concerned about his atrophy. He was concerned about pain. His major complaint was severe, unrelenting pain all the time. Nothing helped. Okay.
Just the shoulder?
Huh?
The pain was in the shoulder?
Shoulder and upper arm.
Okay.
Here's our nerve conduction findings. Normal. Look at his deltoid. Even with that much visible atrophy, his side-to-side amplitudes were within normal limits. Okay, so what does that tell you? What is that atrophy from? Is it neurological or is it something else? Yeah. So what is that something else? Disuse atrophy. Because with disuse atrophy, we still have our functioning axons. We still have all our muscle fibers. They're smaller because they've atrophied, but when you shock that nerve, all those axons are still going to fire and give you a fairly normal amplitude. What's our EMG going to show?
Nothing.
Normal. Everything was normal. Why is he so atrophied, though?
Pain.
Pain.
Pain and disuse.
Projection.
Disuse, not using that arm. Okay. So this was a case, again, in my impression, I said the significant muscular atrophy noted in the left shoulder girdle region in the absence of nerve conduction or needle EMG abnormality may be suggestive of an underlying mechanical joint / soft tissue pathology and disuse. No evidence of focal neuropathy, proximal nerve plexus or nerve root on a pathology or underlying polyneuropathic or myopathic processes. This was a normal test, other than the fact that his left shoulder is screwed here. So this was the case. This case series I presented at CSM this year, and this guy was going to be my normal. He was going to be the guy instead of that lady, that we talked about first. Then, on the 22nd, 2 days before I'm to present this, the PA calls me, okay, in Washington, D.C., and says, "Hey, why did you write this up as being disuse?" Okay, and so that's a question you sort of don't know, you don't want to get. Okay.
Yeah, that's one I would naturally do because
I said, well, because I didn't find anything abnormal. And he goes, "Mark, let me send you some x-rays." Okay. So here's his x-rays from October. These were the x-rays the first day he was seen. Okay. Nothing really here to see. Okay. Got a little bit of narrowing of his AC joint, has some narrowing of his, glenohumeral joint, got a little spur, here, but nothing really, super abnormal here. Okay. You guys holding on to your asses?
Okay.
Holy smack.
Wow.
Oh my
These were the x-rays that were taken on the day that, he called me.
Unbelievable.
And this is the PA right here taking the picture off of the x-ray viewer. Look at that guy's shoulder. And look at his proximal humerus.
So what is that?
That is metastatic disease.
Wow.
That has caused a complete collapse of his proximal humerus.
You are completely right.
I count 1, 2, at least 4 fractures in his proximal humerus. Okay, now look here. This is October the 16th. This is January the 22nd.
Wow.
Go back to your impression and what your impression said. Mechanical joint soft tissue pathology. So looking at underlying mechanical joint and soft tissue pathology.
I thought it might have been like a rotator cuff tear or glenoid labrum tear or something like that.
But it's still you were close.
I was close because everything was normal.
Right.
Not only do our diagnostic tests tell us what's abnormal, to help explain what's going on, they're a critical tool in telling us what's normal also, and guiding these orthopedists and these specialists on where they need to go next.
Now, Mark, he had a lot of night pain issues too. Do I remember? Is that not?
A lot of what?
Pain at night too. Didn't he have a lot of resting?
He had pain 24/7.
Yeah.
Okay.
And it was metastatic. Did he have anything else going on, or was he? I mean, that was the only place it was happening.
Well, look at his lung fields.
Mm-hmm.
Okay. Do you see these, infiltrates?
Yeah.
Oh yeah.
Here. Okay. So anyway, this guy was sent. He got a CT scan of his chest, and I don't have these. Actually, I can tell you what's happened. He got a CT scan of his chest, which showed evidence of very aggressive, small cell lung carcinoma, with infiltration into his pelvic bones, his sternum, his ribs, his scapula, his clavicle, and of course his proximal humerus here. Okay, and approximately 4 weeks after this date here, patient passed away. Yeah, very, very acute, aggressive, type of a problem here. Okay, I've in 24 years of doing this, I've never seen this in a patient. I mean, I've had patients that have had cancer. I mean, I've seen cases of Lambert-Eaton syndrome, in which that patient turned out to have small cell lung carcinoma. I've seen myasthenia gravis patients in which they've had hyperplastic thymus glands, but I've never seen this. This is why the guy was hurting. His entire proximal humerus was basically collapsing on him, and can you imagine how painful that would be?
But dang it, his muscles and nerves were good.
But his nerve and muscles were normal, other than the fact that they were severely atrophied because of disuse.
I'm sure if you ever see this case again, you'll be thinking about that cancer, won't you?
It's sort of funny you say that, Roy. Again, living in Kentucky, I see these people, they walk into clinic and they're 25-year-old healthy guy, walking in on a walker or a cane, and the first thought that goes to my mind is, gosh, man, this guy's FOS, here. And at some point in my career, I'm going to stop doing that.
Yeah.
Because this has happened so many times where I've seen patients that have a severe cervical myelopathy or have a thoracic myelopathy, or other space occupying lesions within their spinal cord, and that explains why they're doing what they're doing. So again, I'm trying to improve myself, by not trying to stereotype people. This guy here, honestly, what didn't make me doubt for 1 second that he had something severely going on is the fact that his muscles were atrophied.
Right.
Okay. I mean, that's not something you can fake there. And, while testing this guy, just moving his arm. I mean, can you imagine the pain that he went through when I positioned his arm to test his motor motor?
Oh, yeah.
Okay. And hell, for all I know, one of them fractures could be mine, from trying to put his arm.
Sure.
I mean, I don't know. Okay. But, again, the take-home message with this is even in the presence of a completely normal exam in a patient with that degree of involvement, this test certainly, was helpful, because I don't think that PA would have taken that second x-ray if that EMG had shown something with his axillary nerve or shown something with his supraspinatus nerve.
Right.
Okay. So this gets back. I'm going to click back to the first slide in this presentation here. And this is our guy. Right here, the question you have to ask yourself as PTs: our standard clinical examination going to be sufficient to find out what's going on with this patient? And what do you think the answer is? No. Okay. We have these tools. We have ultrasound, we have EMG and NCS. That certainly can guide us down the right path and get this poor patient, to a point where he can be, properly treated. And unfortunately with him, he had this, underlying, metastasis that was rapidly spreading throughout his body. Or, at the point that we saw him, there was probably nothing, that had been done even at that point. So, okay, so we've been going for almost 2 hours here now. Any questions for me about anything?
One question I have, just being new on the call, in terms of writing these up and getting, just starting to log hours. And do I need to write up something after this?
Yeah, you could certainly, write up just a little, report, little paragraph that basically, write down maybe 5 items that you learned from tonight's webinar. And that won't take you 2 minutes. Okay.
It'll take me 5, but I get it. Yeah.
Okay. It might take me 2 minutes. It might take you 5. Yeah. Just keep track. Maybe write down the term Parsonage-Turner, and maybe do just a little bit more research. And that time that you spend reading a few articles on Parsonage-Turner, all that stuff counts towards your residency hours here.
Even the time that I spend reading an article?
Yes. That's called self-study. Absolutely. Yeah. Absolutely. And John's probably talked to you about these CATs, C-A-Ts. Critical, they're called critical appraisals. What you could do is, if you find 1 or 2 articles about, say, Parsonage-Turner, just write a 1 or 2 paragraph summary, and that will count towards your CATs.
Okay.
Absolutely. Yeah. Any time spent, interacting in a webinar is going to count. Now, that being said, if you just log on and you mute yourself and you sit back and the system determines that you were inactive during the whole 90 minutes, that ain't going to count, because we can download a report that will tell us what each of you, if you've been active or been inactive here. Okay. But if there's something here that interests you, if, say Parsonage-Turner interests you, or if, upper brachial plexopathy, interests you, go and read a couple of articles and then write a couple of paragraphs, on a critically appraised topic, and that all counts.
Okay.
Okay.
Thank you.
You're welcome. Anybody else?
Great presentation.
Hey, Dr. Brooks.
Thanks so much, Dr. Brooks. Yeah.
As usual.
Yeah,
One of my
thank
pleasure.
you, Dr. Brooks. I really felt like that was eye-opening, going through all those different ones. Just really opened my eyes. And
how many times have we seen these patients in our PT clinics back in the days when we didn't know how to do diagnostics?
Oh, yeah.
A lot, right? Yeah. Yeah. And now we have this tool, in which we can further assess these patients to either help with their management or to get them to who can manage them properly.
Hey, Dr. Brooks.
Yes.
I got a question. After seeing this and seeing that he, had such aggressive metastatic disease, would you now, after doing a study like this, would you say in your impression, possible underlying metastatic disease?
I would not. I would stick to the facts and only the facts. Okay.
Because the EMG doesn't really show anything.
Yes.
I mean, it doesn't lead to anything. They would have only been able to see that with the follow-up x-ray of some sort.
Exactly.
That didn't tell us that it was metastatic.
But what I would say is I would, again, with that patient I saw Monday, which I thought might have ALS, and I wrote referral to, neurology or other neuromuscular specialist strongly suggested.
Okay.
Or I may say, please correlate clinically with imaging or other diagnostic studies.
That makes sense.
I'll say something like that, but I'm certainly not going to suggest, a specific disease process here because I don't know.
My slant as a physical therapist, seeing someone come in doing that degree of pain, obviously, if you don't know the client, you don't know yesterday from the day before, you don't know personality. I mean, that's where it's so valuable to have a relationship with some people because they come in and you got it this slate and you're just trying to interpret it. But for a guy like that, to have that kind of pain, if I was getting maybe even more, a little bit more in a snapshot, like if I knew him, then I would be like, basically I would probably put something on the report, like, additional follow-up, medical follow-up is, appears warranted.
Absolutely. I mean, absolutely. Or, and again, I tell patients, I said, I'm going to talk to your surgeon, and we're going to see if they can't get you back in as soon as possible. And several times a week, when I'm done seeing a case that I think needs to be followed up quickly, I'll walk with that patient up to checkout and I'll say, he needs to get in to see Dr. Rice or Dr. whomever as soon as, he's got an opening, and then I'll say, does he have anything available tomorrow or the day after? Okay. And
to follow them so that they get what their next piece.
I want to make sure that they're, that I'm getting them to their follow-up. Okay. Now, if they call back later and cancel, that's on them. Okay. But what's nice about what we do, okay, I was with this guy for probably close to an hour. Okay. I'm talking with him and I'm developing a relationship with this guy to where he can trust me. Because I'm testing him, but I've also got almost an hour to talk with him. And he had his son in the room with him. And we're talking. Okay. And I told him, I said, look, his nerve test, his EMG was completely normal. What that tells me is that this is something non-neurologic. This is something bone, joint, soft tissue. It's something. Okay. I had no idea. I mean, I literally had no idea. Ask Rick and Mohini, when you see them. I got the phone call when I was with those guys. And, so I put the phone down and I said, do you remember case number 1 in my, and they goes, and she goes, yeah, the guy with the reels. I said, he's going to send me some x-rays. And these x-rays came in and we looked at them as a group and it was like, holy cow.
Yeah.
You know, so yeah, you know, I said, so guys, I'm going to have to revise my presentation, you know, here now, you know, so yeah, so. Okay, guys.
Mark, are you
Well, thank
presenting
you very
again?
much.
I'm sorry?
Are you presenting
Thank you.
again next Wednesday?
I am not presenting next Wednesday. Apparently, this was Rick's night to present, and he didn't tell me that until like an hour ago. So we're just going to switch because next Wednesday I'm traveling to New York to do a mentorship up in New York, and then I'm teaching the stage 1 training next weekend. So next Wednesday will be Dr. McKibben doing a.
Okay, thanks a lot.
Yeah,
That was
thank
great.
you.
Okay.
Hey, thanks.
Thank you
Thanks,
again.
guys.
That was excellent.
Have a good
Yep.
evening.
Next
very
time.
much.
Look
Yeah,
forward to it.
call me or email me if you have any questions about anything. Okay.
Sounds good.
Okay, sounds good. Thank you.
Right on.
Thank you, Dr. Brooks.
Thanks.
Bye bye.
Thanks.